Hi, I'm Jeff Klein, editor of RadioGraphics, and today I'm pleased to have with us Dr. Ravi Gottumukkala, Michael G., and Mary Greer from the Departments of Radiology at the Massachusetts General Hospital and the Hospital for Sick Children in Toronto, Canada, who are authors of one of our featured papers in the current March 2019 issue of RadioGraphics. Their paper is entitled Current and Emerging Roles of Whole Body MRI in the Evaluation of Pediatric Cancer Patients. Doctors, welcome to our podcast. So, Ravi, I'm going to begin with you. Your paper reviews the use of whole body MRI as an imaging tool for children with known cancer and for those who are being screened for cancer predisposition syndromes. The article begins with a review of the technical aspects of performing these studies, and in particular, the utility of coronal stir sequences in these examinations. Let's show Table 1 as you go through the details of the protocoling of these examinations.
Sure. First off, I want to say, Dr. Klein, thanks so much for having all of us. We're all very excited to talk about this topic that's, we think of import to the pediatric radiology community. So for whole body MRI examinations, I think that the big principle is that we're referring in a most strict sense to imaging from vertex to toes, but that can be modified to be sort of multiple contiguous body regions like the neck, chest, abdomen, and pelvis, limiting to that depending on the indication. So I think the big overarching theme I want to start with is just by saying that, I think it's important to get diagnostically useful information within a reasonable time frame with this examination, because you can really have sequences that end up taking a lot longer, if you're not a little bit judicious with how you select them. So that's where these sequences come in. So I think it comes down to having two key principles, which is the right hardware and also good sequence selection that are sort of high yield for the diagnostic purpose you want. So I'll quickly just talk about the hardware. So I think one principle for this with respect to hardware is to try and minimize time that's spent basically shifting coils around and moving patients around in between the different sequences. And so to the extent that you have hardware like a moving table platform, for example, and coils that you can position at the beginning of the examination that will allow you to seamlessly transition from one body station to the next, that can be very helpful in minimizing the lag time in between sequences. So that's a big thing. And I think having dedicated multi-channel coils as well that are surface coils as opposed to using the in-bore magnet coil can be very helpful in improving your signal-to-noise ratio and thereby minimizing time and maximizing image quality. So that's sort of the hardware piece. I think with respect to Table 1, the sequence component of things, one thing that you'll see if you look at Table 1 is that there are variations in the protocols that are used depending on the institution. We have ours listed on top, but other institutions, they have their own set of modified protocols. But the commonality you see emerge within all of those is that coronal stir sequence, which we find to be reasonably efficient and very valuable in terms of highlighting pathology. So the big benefit of that sequence is it really nicely suppresses all of the background signal from tissues, including fat, and really highlights lesion conspicuity nicely, just because anything pathologic will show up nicely on a stir sequence, particularly osseous lesions in the marrow. And so we find that to be a very high yield sequence. And we like to do coronal because that allows you to have the minimum number of slices. So your through plane slices will dramatically affect your imaging time. So if you do it coronal across all those stations, that's sort of the preferred plane. So that's the stir sequence. Every protocol you see up there has that. And then other sequences that can be useful are basically a single shot fast spin echo or haste sequence, depending on which vendor you have. That's useful because it gives you a lot of bang for your buck in terms of the amount of time it takes to do the sequence, which is usually about 15 to 30 seconds, but also gives you reasonably good anatomic detail. It can be done either with a breath hold or even free breathing. And so it's useful in potentially evaluating in other planes like the axial plane where it complements the coronal that you get with the stir, and is also good for looking at the bowel potentially, just because the GI tract against the abdominal fat that's not suppressed on an axial haste is really nice for that. Beyond that, we do like to add in a T1 weighted sequence. That tends to be very good for marrow lesions. You'll see that in a couple of the protocols on the list as well. And so that tends to be useful when you have sclerotic marrow lesions that may not show up well on a coronal stir sequence. So those are highlighted nicely because you have background fatty marrow signal. And finally, you'll see this in fewer of the protocols, but it's one of the sort of emerging components of whole body MRI exams, which is a DWI sequence. And now as we're able to do that faster with techniques like simultaneous multi-slice imaging, it's more feasible to do that as part of our exam. And it adds really a nice functional component in because the rest is sort of anatomic, but this offers the ability to potentially allow functional tissue characterization, measurements of ADC values and things like that, and really highlights things like lymph nodes and other lesions very nicely, especially when they have high cellularity. And so that's the overarching sort of, I think, hardware and sequence themes of whole body MRI.
Terrific. Thanks, Ravi. So now the paper reviews, obviously, the strengths and weaknesses of whole body MR for oncologic indications. Can you detail which body regions in particular are best suited to this examination, and then maybe touch on some of the limitations of the technique?
Yeah, absolutely. So I think some of the big principles with respect to regions that it's best for are going to be related to what MRI is best for as we traditionally think about it. So for one, we always think of MRI as sort of the gold standard modality in the brain. So any sort of pathology or predisposition syndrome where you're looking for brain or things involving the neck where you really need that soft tissue contrast and anatomic detail, MRI is going to be very good for. So including brain sequences as part of, for example, a patient who has a hereditary paraganglioma sequence to look for things in the neck is very useful. Liver is another area where it tends to excel at, particularly if you add in dedicated liver sequences, just because your tissue contrast in the liver is always going to be superior with MR as compared to CT. And then I think where it really excels at as far as staging is in osseous lesions. And the benefit there is with that coronal star sequence, you can really nicely suppress the fatty marrow background and have lesions pop out very nicely. So I think those three areas are where whole body MRI really shines, and those are areas where you're often looking for metastases in the liver and bones, and depends on the malignancy you're specifically looking for. So as far as limitations, I think the two areas that are worth mentioning are we tend to want to look at the lungs when we're staging certain types of cancers. And I think at present time, whole body MRI and MRI techniques in general are not quite at the point where they can supplant CT just because you have that really high spatial resolution on CT, looking for these tiny nodules in an organ that doesn't sort of have much intrinsic signal on MR sequences. And so when you're looking for lesions that are less than, say, about 6 millimeters, it can be challenging to reliably have sensitivity for those with MR sequences. And so for malignancies where we specifically want to stage for lung metastases and where those might impact management, we still routinely will use a dedicated chest CT for that. But relative to other areas of the body where you have to employ CT, the radiation dose is somewhat lower because it's a tissue that penetrates more easily. So lung is one area I would say where we're still working on sequences that can potentially help highlight the conspicuity of small pulmonary nodules. And then the other area is with lymph nodes. I think this is always the classic challenge with CT as well, where with anatomic imaging, where you're going by size criteria as compared to PET. Size criteria can be misleading. You can have prominent lymph nodes that are over a centimeter that are just reactive. You could have sub-centimeter lymph nodes that can be missed on whole body MRI in some cases, or that you don't necessarily classify as being pathologic, but that are actually involved. And so that still, I think, remains a challenge. And DWI to some degree is helping clarify that. I think going forward, as we are better able to have DWI sequences where we can measure ADC values in smaller and smaller lesions, that may be something going forward that we can be able to use MRI for, is to differentiate in the same size node whether one is potentially malignant based on ADC value versus the other not. But I think at present time, the anatomic component of nodal imaging is still to some degree a limitation of that.
Sure. Well, that's terrific, Ravi. Thanks so much. So Michael, let's move on. After you review some contrast agent issues and rapid acquisition techniques, including, as Ravi mentioned, simultaneous multi-slice imaging, and also you touch on sedation issues, as well as billing for whole body MR, which is obviously an issue that needs to be addressed. Your paper reviews applications related to pediatric neoplasms, beginning with lymphoma. Let's look at figure 2, if we can, I think, which nicely illustrates the case of Hodgkin lymphoma.
Sure, and again, I just want to reiterate that I wanted to thank you and the staff from RadioGraphics for giving us the opportunity to talk about our work. Some of the figures that are in the paper subsequent to the table 1 are giving specific patient examples of applications of whole body MRI and how lesions that are seen on whole body MRI compare to their appearance on other imaging modalities. So figure 2 is an example of a 17-year-old patient with Hodgkin lymphoma who had both a PET CT as well as a whole body MRI reasonably closely spaced in time. And it gives us an opportunity to compare the different modalities. One of the assumptions underlying the use of whole body MRI that I think you touched on earlier is the fact that in children who have a high likelihood of having cancer and are likely to need multiple imaging studies over time, the main advantage of whole body MRI is the lack of ionizing radiation. And so this is an example in figure 2 of a newly diagnosed patient who has cancer. You can see in panels A and B, Ravi mentioned the single shot T2 sequence as well as the DWI sequences that are a really important part of whole body MR. The idea of DWI, again, is that we're trying to look at the relative motion of water molecules inside of cells. And the idea is that patients who have cancer, that cancer cells are very densely packed within tumors. And so we see that restriction in water movement within those cancer cells as a relatively low ADC coefficient or a low ADC value. It's something that's reproducible and quantitative and goes beyond the anatomic visualization of tissue. And similar to what Ravi was saying, in lymphoma patients, the current gold standard is PET CT. So we use the CAT scan portion of a PET CT, which is figure C, panel C and panel F of that figure, to show both that there are lymph nodes that are enlarged. And then we use the FDG PET portion of the PET CT to look at metabolic activity. Again, FDG is a glucose analog. It's taken up by cancer cells that are highly metabolically active. And so in panel D, what we're seeing is that those very dark spots within the lymph nodes are showing us that those are lymph nodes that are very highly metabolically active and much more likely to be cancerous. And so comparing panels B and D are showing us that the use of DWI is able to get us similar to the characterization of PET, obviously by a different mechanism. PET is showing us that these are lymph nodes that are metabolically active and likely cancerous. DWI showing us that these are lymph nodes that are very densely packed with cells and also likely to be cancerous. So again, part of when you're trying to diagnose cancers in children at an early stage is that not only do you want to see them anatomically as masses and lesions in the body that aren't supposed to be there, but in subtle cases where you might not see a very big tumor, can you look at that functional information? And so, this is a nice example showing that the functional information of DWI complements MRI in the same way that PET complements PET CT.
Terrific. Great. Well, Michael, in discussing the use of whole body MRI in solid malignancies, you focus on the evaluation, in particular, of small round cell tumors such as neuroblastoma, Ewing, and rhabdomyosarcoma. Let's review figure 6, which shows the utility of MR in a patient with Ewing sarcoma.
Sure. Again, so this is a 13-year-old male who had metastatic Ewing sarcoma, and again, really highlighting the power of whole body MRI to diagnose lesions in multiple body locations. As you and Ravi had discussed earlier, there are certain areas of the body that MRI is naturally very good at looking at, areas such as the brain, such as the bony pelvis, because there's a lot of soft tissues, fine soft tissue structures in those areas that need to be distinguished, and the intrinsic soft tissue contrast of MRI is better in those locations than CT, which is basically just imaging on the basis of X-ray beam attenuation properties. So that's really not getting at sort of more of the soft tissue characterization that we can use with MR. So this is an example of a patient who had a pelvic Ewing sarcoma, had a lesion in the femur, which you can see in panel A, showing that the corresponding lesion on a CT scan that was performed closely spaced in time, that finding was very subtle on CT. And again, one of the advantages of MR is bone marrow characterization. And so you can see on that stir image, as Ravi was talking about earlier, not only the cancer cells themselves that have increased water that can be seen on the stir image, but the fact that many of these aggressive malignancies elicit an inflammatory reaction from the surrounding normal bone. And that inflammation that surrounds it is something that we see very well in MRI, and part of the reason why MRI is often better than CT in subtle bone lesions. Ewing sarcoma, as we know, is an aggressive bone malignancy as well. And so these are tumors that tend to grow very quickly and again induce a very strong inflammatory reaction. The other panel figures were showing some additional metastatic lesions in other parts of the body. I highlight the panel E, which is actually a lesion in the lungs. It was an 8 millimeter metastatic pulmonary nodule. The patient had had a CT scan previously that had documented that it was there, so it was a lesion that was already known. But the lung is traditionally thought of as an area that MRI is relatively weak in because of the fact that the air in the lungs can affect the magnetic field and cause susceptibility artifacts that can make it difficult to see lesions. But showing that in cases where you have good image quality, again, patients are also breathing, and that respiratory motion in the lungs can also make it difficult to see lesions. But in cases where patients are cooperative and lesions are solid and not ground glass or not sort of other lesions that are not as solid and not as well seen, MR actually does have very good spatial resolution for seeing small lesions. And so that was an example of a small sub-centimeter lesion that MRI picked up very well.
Terrific. Thanks, Michael. Mary, let's move on to talk with you. Mary, the latter section of the paper reviews the cancer predisposition syndromes. It looks as though the American Association of Cancer Research has a defined role for whole body MR in screening for selected syndromes. Let's take a look at Table 2, which provides a summary of their recommendations as they relate to whole body MRI. And perhaps you can focus on those syndromes where you currently employ this technique most often.
Absolutely, and reiterating from Mike and Ravi, thanks again for the kind invitation to participate in the podcast. So the AACR brought together a team of different clinicians across the spectrum in pediatrics in the end of 2016 to really address this issue of surveillance in cancer predisposition syndromes in children. The threshold that was established in terms of working out whether surveillance was warranted or not was really the determination that if there is a chance of a tumour happening under 20 years of age that's 5% or more, then some sort of surveillance is justified. And the group of people brought together involved people from obviously genetics, pediatric oncology, endocrinology, and radiology. My colleagues Lisa States and Sarah Voss participating in this on the radiology side. And from this, we distilled, after looking at around about 50 different syndromes, that there were a handful for whom we could reasonably justify performing whole body MRI for all the reasons that Mike and Ravi have articulated in terms of its increased conspicuity of lesions, but really minimising the risk of adverse effect, we hope. One of the challenges obviously being the use of sedation or anaesthesia. And certainly the balance in that has determined who we image, when we start, when we stop. The key ones that we tend to look at most commonly here at Sick Kids is Li-Fraumeni syndrome and also the hereditary paraganglioma pheochromocytoma syndrome. We have a small number of other syndromes that we image less regularly, and the thing that's important really to remember, these are recommendations. There's not a lot of evidence as yet. This is a starting point, drawing on experience from the literature as well as to different clinical groups that have already established some guidelines, and we fully expect that these will evolve over time, and indeed the ACCR is currently in the process of asking us to look at those already in 2019 to see if we can modify those. So in particular, Li-Fraumeni syndrome is one area that is of high value. We've done some studies that under the guidance of David Malcolm and Lisa and Anita Villani here at Sick Kids, looking prospectively at two groups of patients that were streamed into by patient choice, surveillance and non-surveillance, and those patients that elected to have surveillance, of which whole body MRI was a crucial part, and together with clinical examination and biochemistry, the 5-year survival was around about 90%, whereas those patients who elected not to undergo surveillance, the 5-year survival was closer to 60%. So there is certain value, and in those patients that malignancy was identified, about 30% of the studies was solely due to whole body MRI. And when we added dedicated brain MRI into that, the yield was about 50% for malignancy. So there's certainly been shown to be evidence in this patient population, as leishman syndrome, in whom there is a significant lifetime risk of cancer. And in terms of the type of imaging that we perform for these patients, when they've been diagnosed, we carry out whole body MRI, and in this instance we do vertex to toes or head to feet for these patients annually. We then do dedicated brain MRI with contrast the first time round, and then unless there's an abnormality shown, we'll elect to do it without contrast for ongoing surveillance. And when they reach the point of not needing any sort of sedation or anaesthesia, and typically at sick kids we will use GA for the most part, then we'll interleave doing whole body MRI with a less detailed brain study to doing a more detailed brain study in conjunction with whole body MRI, and alternating between those at 6-month intervals for their lifetime. But certainly that's been the syndrome that's really been the one that we have shown the most evidence and value for the utility of whole body MRI and surveillance screening, and ideally to be able to pick up the related tumours. And this patient population, it's things along the lines of different brain tumours, adrenocortical carcinomas, osteosarcomas, soft tissue sarcomas, and as we get into the early 20s, early onset of breast cancer are the key ones. And so it's certainly shown value in those. The other syndromes are less high incidence of malignancy, but certainly with things like hereditary paraganglioma and pheochromocytoma, we certainly do see PHEOs in those patients. We've shown some examples in our paper of one patient with that, and related malignancies that can be renal tumours, for example, as well, of lower incidence.
Terrific. So, Mary, to follow up on that, can we review Figure 13, which shows the use of a coronal stir sequence in patients with neurofibromatosis type 1?
Absolutely. So this patient population is a group that we don't image as often, obviously, as leishman syndrome. We typically suggest with these patients that they just have one whole body MRI, again, vertex to toes, at that point where they transition from pediatric to adult care. And so in this example, it's a 15-year-old boy who had a coronal stir, our workhorse sequence. And this has shown that there are a number of plexiform neurofibromas, particularly involving the brachial plexus in the paraspinal region, in the cervical thoracic junction, as well as in the lumbar region. And in addition to that, some pelvic tumours there as well. And they have the characteristic appearance of the target sign that we see on T2-weighted sequences as stir and flat express T2 or T2 haste, as we've suggested as alternate sequences. And the utility of this in these patients with neurofibromatosis type 1 is to really give us an idea of the location, the number and the size of lesions. And over time, that forms a baseline, looking for evidence of any rapid increase in size. We don't typically do contrast at this point. This is purely for surveillance to determine disease burden. And if we have ongoing symptoms of pain or increase in size, then we might elect to do contrast and do some more high-resolution targeted imaging through an area of particular clinical concern.
Terrific. Well, thank you for that. So Ravi, Michael, Mary, I want to thank you for taking time today to discuss your paper on the use of whole body MRI in the evaluation and screening of pediatric cancer patients. The paper can be found in the current March 2019 issue of RadioGraphics. Doctors, thanks so much.
Thank you.